Mr. Fonagy, you have become known especially for the conceptualization and the study of the concept of mentalization. What were the historical and research settings that allowed you and Bateman to define it?
It's an interesting and important question. We started from the concept of the French school, the Parisian school of psychosomatics, had a concept of mentalization, which was a psychoanalytic concept that actually related to the libidinal binding of or the binding libidinal binding of ideas, which really had nothing to do with how we conceptualized mentalizing, but we started from the concept of theory of mind that emerged in the 1970s, the late 1970s, early 1980s. We felt dissatisfied with the concept of theory of mind, and we reformulated it as mentalizing, which, whereas theory of mind pertained simply to an understanding of action in others in mental state terms, we extended it slightly to mean interpreting behavior in oneself and in others in terms of intentional mental states, thoughts, feelings, wishes, desires, and so on. So it was an extension of both the concept of theory of mind, but also the French psychoanalytic concept of mentalization. The mentalization was actually all about mentalizing your, having a mental representation of your own thoughts and feelings, and the cognitive psychology concept of theory of mind was all about others' understanding of behavior in terms of thought and feeling, and we compressed the two together to use the French term and the cognitive, emotional, social-cognitive definition. So that's the context of it.
Over the years, how did this concept change and how did it evolve in the clinical practice? In addition to BPD, have there been new mental disorder affected by the MBT protocol?
Mentalizing actually originally was applied to the capacity of mothers to be able to interpret their infants' behavior in context of mental states. So the first measure that we developed for mentalizing was about the mother's capacity to think about the infants in mental state terms. And what we found that this measure, when applied to individuals with borderline personality disorder, and that was in quite some time ago, in nearly 20 or so years ago, that individuals with borderline personality disorder did very badly in that measure, which actually gave us the idea that perhaps that was a problem that was specific to them. And we then developed the therapeutic approach that focused around that problem. As we were working with that group, we found that other groups with severe behavioral problems, like those with eating disorder, those with problems of uncontrollable aggression, that were usually diagnosed antisocial personality disorders also had a very similar apparently deficit in the way they managed their internal economy, their thoughts, their feelings. So we extended it to other populations. We also found that individuals with depression had problems, that children with conduct problems had mentalizing problems. So gradually we began to see this as something that many disorders have in common, as an issue that manifests in slightly different configurations associated with particular diagnoses, but actually there is a way of conceptualizing it, and that's the time that we then, with Patrick Luyten, developed a way of trying to profile the nature of difficulties that people had in mentalizing by arguing that mentalizing was a balance between thinking about oneself and thinking about others. It was a balance between thinking about external things and thinking internally, thinking about cognitions and thinking about emotions. And so thinking implicitly or being very reflective. And that good mentalizing was achieving a balance between these polarities. So someone with narcissistic personality disorder would have no difficulty in being quite sophisticated about the way they thought about themselves, but had real difficulty in understanding or appreciating the impact that they were having on other people. We're starting to put together profiles of deficits in the use of mentalizing that were associated with an imbalance. People thinking too much about themselves, too little about others. And these profiles: self, other, implicit, explicit, cognitive, affective or cognition, emotion, and internal, external. These also then gradually helped us better define what we were trying to do therapeutically. So if someone who was mentalizing poorly spent too much time thinking about other people and not enough time thinking about the impact that other people had on them, in a context of a therapy, we could try and shift the balance. If they spent too much time talking about the thoughts that they had, but too little time about the feelings that they experienced, we could shift, moving them from cognition to emotion to achieve a better balance. So as the concept evolved, rather than thinking about an all or none, mentalizing or not, we thought about good mentalizing and less good mentalizing, where good mentalizing was characterized by a balance between these polarities, and poor mentalizing was being stuck at one end of the of those polarities, rather than being able to shift flexibly between the two.
In the evolution of your studies, you have come to elaborate the concept of epistemic trust, understood as the truth in the authenticity and in the personal relevance of the interpersonally transmitted knowledge. Could you talk more about this concept and its impact on the social context of an individual?
We initially, when we started out on our journey, we thought most often in terms of attachment relationships. And gradually, we realized that attachment wasn't everything, that there were people who had relatively good attachments, and yet they had significant problems. And similarly, that people who had poor attachment and appeared not to have problems. So we started thinking about that these attachment or the disorganization of it and mental disorders were overlapping but not identical concepts. And that's what started us thinking more in terms of communication rather than simply in terms of attachment. So that we thought that individuals who were struggling with mental health problems, for the most part, felt isolated from genuine communication with others, where they were able to trust other people enough to modify their experience of themselves and their experience of others sufficiently to respond flexibly to changed circumstances. So they would become rigid or appear to be rigid and unchanging or unchangeable. And we identified that perhaps the reason for this was a lack of trust in the communication that they received, that it wasn't so much that they didn't understand what they were told, but they simply didn't trust that knowledge, and that in order to be impacted or affected by what other people communicate to you in a fairly constant way, you actually have to have trust of that communication, the trust in that knowledge. And that this was perhaps a very broad concept that characterized us as a species, as Homo sapiens, because we are the first species to have culture, to pass on knowledge from one generation to the next by communication. And when you have to do that, you have to be able to differentiate people who you can trust, to whom you want to open your mind up, to be influenced by them, and people that you should be suspicious of, where you should have epistemic vigilance in relation, trusting that piece of knowledge. And we feel now quite strongly that individuals who have mental health problems actually are struggling with an inability to trust that leaves them feeling quite lonely sometimes and isolated from the network of communication that most of us benefit from. Certainly, I think that one of the most common features of a wide range of mental disorders is people who have a sense of isolation. Why should people feel like that? I think that when we look at just how common maltreatment or abuse or adverse childhood experiences are in the patients that we see, I think we can probably anticipate that those who have had experiences of maltreatment would have much greater difficulty in extending trust towards information they receive from others. So in a sense, it's understandable that epistemic mistrust or epistemic vigilance or even epistemic hypervigilance should be associated with a history of adversity in childhood, which actually makes people very suspicious, but at the same time makes them less flexible, less able to take on new information, and be more rigid and to feel more isolated in a social context.
Which advantage does integrative psychotherapy bring compared to more classic approach?
Integrative psychotherapy is in a sense, the prototypical psychotherapy. I think all psychotherapies are, in a sense, integrative, because there are very few forms of any school of psychotherapy. I've been practicing psychotherapy for 40 years, and to see pure of anything, whether that's pure psychoanalysis or pure cognitive behavior therapy or a pure systemic approach, I have yet to see it, because people in practice actually integrate a number of influences that they, as people, bring to the new relationships they're developing with their clients. So to me, integrative psychotherapy is psychotherapy, but it's also one that can sometimes be unhelpful for people, because they are not so sure as to where they are or what they're doing or how they can actually integrate different forms of therapy. And that if they are confused, they leave their clients confused, and that is unhelpful. So whilst I'm very much in favor of integrative psychotherapy, which I think is a very good way of bringing epistemic trust or creating epistemic trust with your client, so that they actually develop epistemic trust in relation to others, and be more open to that kind of social messaging that they excluded themselves from. I think there is integrative psychotherapy that is not fairly well described, and leaves people wondering too much as to what's right and what's wrong, is less helpful, because it leaves people confused. What I think is important in psychotherapy is for the therapist to have a clear image of the person that they are talking to and the person that they're talking with, and to talk in a way that helps that person clearly see that they are being imagined, that their imagination of themselves is being accurately imagined by the therapist. And if they perceive that, then they will develop trust for that person, and a communication can begin, really regardless of the topic of conversation, but conversation can begin that helps them learn about themselves. And if they have that experience of a meaningful conversation with somebody else about themselves, about their context, about their situation, then they can turn to the world outside and experience, have a much more nuanced, much richer view of those experiences, and the regaining of epistemic trust for the social world outside, I think, is the driving force of psychological therapy, regardless of school, regardless of modality, regardless of orientation.
In your opinion, what are the more interesting innovations in the field of mental health?
I think I spent a little bit of time, because you gave me an opportunity to look at these questions. I spent a little bit of time thinking about that. And I think I wanted to mention two things in particular. The first is the general recognition now that the diagnostic systems that we have been working with are probably sometimes at least unhelpful. That what we see most commonly are not unique examples of depression or anxiety or conduct behavioral problems, or even psychotic conditions. Very rarely are they simple diagnoses. Most people come with 2 or 3 different diagnoses. And the reason for that is probably that actually we have been thinking about diagnoses in a wrong way, that there are indeed specific diagnoses, but underneath that there is also a very general vulnerability to psychopathology, so that psychopathology comes in at least two levels. The first is a general vulnerability to any kind of disorder, and then the specific form that it finds. Now, the reason I think that's an important distinction, because very often psychotherapy aims itself at the specific symptom, not at the general vulnerability. And I think, to me, epistemic vigilance or epistemic hypervigilance is part of the general vulnerability that psychotherapy in a transdiagnostic way addresses. So one of the important developments, I think, is the transdiagnostic nature of psychopathology. And the second is the, and not unrelated problem, is the gradual recognition of the importance of social context. That psychopathology is not simply inside an individual's head, but actually is a part of an individual's connection to their social world, so that a person is not suffering in themselves except for being disconnected from their social network. And that very often we try and address an individual's problems mainly or purely in terms of their subjective experience, and perhaps pay less attention than we should to the framework that they are in, the social framework that they are experiencing. And I have certainly made the mistake of believing that I've done a good piece of work with a client who I then discharged to a social environment that was unsupportive, or even certainly was not benign and may have been in fact hostile, and they were worse off than they had been before they came to see me, because before, that epistemic vigilance, the hypervigilance about their social environment, served them very well in the context of that hostile environment. But making them more trusting of that environment actually made them more vulnerable. I've removed their defenses, if you like, and that was unhelpful. So that I actually need to pay as much attention to the social environment, the social context that my clients are in, their relationships, the social network, as I need to pay attention to their individual constructs, their individual thoughts, feelings, beliefs, wishes, and desires. These are the two things I wanted to mention.
Nowadays, what are the biggest limitations in the treatment of personality disorder?
Time is the biggest limitation. That in many instances, because of misinterpretation of the evidence, particularly funders of therapies feel that a brief treatment will be substantial, will be important enough to help an individual whose problem is persistent. Personality disorder is, in a way, not a problem of personality. I think personality disorder is a problem of communication, a problem of general mistrust, and that to address that, we have to help that individual regain trust. If we are treating simply their depression, I think we are only treating the specific problem and not the underlying vulnerability. I think we really need to be very clear about those two levels, the specific problem and the underlying vulnerability, because personality disorders are largely problems of an underlying vulnerability, the whole range of disorders. And I think that actually needs more time in a therapeutic context than funders are willing often to pay for. And that's, I think, is the biggest challenge.
The last question. What advantage and limit from your clinical observatory in the DSM-5 demonstrating which correction could be made in order to turn it into a more valid clinical instrument?
But this touches on the issue that I raised. I think DSM-5 is not fit for purpose. It describes a phenomenologically defined reality. That is, a patient is asked, what do you feel? And the patient says, I feel anxious. And the therapist or the clinician says, well, I think you've got anxiety disorder. I'm exaggerating to make a point, but DSM-5, as indeed all the phenomenological diagnostic systems, actually are based on symptoms. And I think that's the wrong level of analysis. It's not that I don't think that symptoms need looking at, but when you do studies of the way symptoms relate to each other, what you find is that there is this general super disorder, a general psychopathology factor that actually underpins all the specific disorders. DSM doesn't make that distinction, and I think it should. And really, how could it make this distinction? By actually looking at comorbidity, the co-occurrence of mental disorders, as an indication of general vulnerability. The second issue is that because the specific and the general have correlated poorly in the past, the link to particular mechanisms in terms of neural mechanisms or even behavioral mechanisms or even social mechanisms are poorly defined. And I think the NIMH attempt to try and look at that ARCADS, is an important advance, trying to look at mental disorders in terms of the mechanisms underpinning them. But as long as you stick to the diagnostic system, you will not find a simple correspondence between a diagnosis like depression, which is an extraordinarily heterogeneous problem in terms of the number of mechanisms that are underpinning it, and the neural mechanisms that you might be investigating or the psychological mechanisms that you might be investigating. So to me, there are two problems. One is that the clustering of diagnoses is not how things are in reality, because it conflates general vulnerability with specific problems, and consequently that the clusterings will not correspond to mechanisms that are relevant at brain level or at the level of behavior or at the level of social context. What this results in, and this is the main difficulty for us in mental health at the moment, is that we have not been able to bend the curve, that our colleagues in physical health have been able to reduce the prevalence of physical disorders, being able to prevent many physical disorders, cancers, cardiovascular disorders, so that they've been able to prolong life. In mental disorder, we are treating symptoms, and we have not been able to genuinely bend the curve, to genuinely reduce. We have been able to relieve distress, but not genuinely reduce mental disorder in terms of cure or in terms of actually comprehensive elimination.
Thank you.
Is that what you were hoping for?
Oh?
Is that what you were hoping for? Did I say what you wanted me to say?
For me, it's okay.
Okay, good.
My questions are clear?
Yeah, your questions were very clear. Thank you for sending them in advance.
No, thank you for your time.
And it's my pleasure. My pleasure. Okay, take care.
Sì.
Bye bye.
Bye bye.
Yeah.